Good afternoon, ladies and gentlemen. Welcome to an interactive BJUI session. I have requested the two speakers to talk for 20 minutes, and then they'll be happy to take questions from the floor. First up is a legend. This is his first BAUS, and I call him an ideal grade urologist. IDEAL stands for the ideal principles, which he's going to tell you about. It hails from Balliol in Oxford, and he's also chairman and founder of the GRADE working group. Dr. Philip Dahm serves as Director of Research and Education for Surgical Services in the Minneapolis VA, and is also Professor of Urology at the VA at the Department of Urology in Minnesota. He leads the Cochrane Prostate Diseases and Urologic Cancers Group and is a master on evidence-based medicine. Here to tell us about systematic reviews, his pet subject, I give you Philippe Dahm.
Thank you very much for this wonderful introduction, Prokar. It's a real pleasure for me to be here today and to talk about systematic reviews and their role in evidence-based urology. I would like to dedicate this lecture to two individuals that are important to this topic. Number one, David Sackett, by many considered the godfather of evidence-based medicine, founder of the Center for Evidence-Based Medicine at McMaster in Hamilton, Ontario, and then he went on to do similar things in Oxford. Unfortunately, he passed away approximately 6 weeks ago. The second individual needs no introduction to this audience, Dr. John Fitzpatrick. Among many things, he was a pioneering editor for BJUI International and has always recognized the importance of evidence-based medicine to urologists. Also, just wanted to disclose any potential conflicts of interest. As you know, I'm here by kind invitation by BJUI International. I also wanted to disclose my potential intellectual conflicts of interest. I'm a long-standing member of the GRADE working group that you'll hear about. I serve as coordinating editor of Cochrane Urology, previously known as the Prostatic Diseases and Urological Cancers Group, and I'm also been consulting editor of BJUI International, and once again, I'm delighted to be here. So, you all know the paradigm of evidence-based medicine, which is that decisions about the diagnosis, treatment, and healthcare management of both individuals and populations of patients should be based on evidence, ideally on high-quality evidence. And less obvious, but also true, is that few important questions in healthcare are appropriately addressed by consulting just a single study. Now, unfortunately, there are many examples in the medical literature where healthcare has gone astray and we've done things to our patients that ultimately have been shown not to be effective or in fact harmful. One example is bloodletting that was actually practiced into the early 20th century. An example of lack of effectiveness, potential harm. Another more recent egregious example was the use of thalidomide or Contergan, especially in Germany, marketed over-the-counter to pregnant women suffering from morning sickness, which was shown to result in these disfigurations of subsequently born children, illustrating lack of efficacy. And finally, the example of the class 1 antiarrhythmics, which is an example of agents, a group of agents that was thought to be helpful in preventing complications in patients undergoing an MI. These drugs actually did decrease the rate of arrhythmia events, but also increased the risk of death for cardiac mortality by 2.5%. And it is estimated that due to the use of these drugs, 28,000 to 65,000 patients died, due to interventions, through to medical interventions, which approximates the number of patients that died in the Vietnam War. Unfortunately, only the latter have been given a memorial in Washington, D.C. So this is an example of an over-reliance on surrogate endpoints and failure to perform a systematic review on the topic. So we now realize the need for evidence synthesis. In fact, we see it as an ethical obligation to summarize the available knowledge, to guide clinical practice, as well as to guide future research, and thereby to avoid unnecessary trials if reliable knowledge already exists. So clinical trials today should be preceded by a systematic review. This has been clearly recognized by many leading journals, including BMJ and The Lancet, both based here out of the UK, as well as many national funding agencies, once again here, Denmark and the Netherlands. And I think this principle is well illustrated in the recent landmark trial by Rob Pritchard looking at the use of medical expulsive therapy. If you read this article, you'll see a section where they looked for pre-existing systematic reviews. They found 2 recent high-quality reviews. One of them was by the Cochrane collaboration published in 2004. That showed that there were actually 27 existing randomized controlled trials on the topic. Nevertheless, these trials in aggregate provided low-quality evidence to support the use of medical expulsive therapy and provided a rationale for one further high-quality trial that you all know about. So systematic reviews are a prerequisite for randomized controlled trial. So what is a systematic review? I'll read you this definition: a study that uses predefined, systematic, and a transparent approach to identify, select, appraise, and summarize primary studies, addressing a focused clinical question using methods to reduce the likelihood of bias. To better understand that, it's helpful to go through the process mentally of doing a systematic review. At the beginning is a focused clinical question. You then write a protocol that outlines the exact steps of what you plan to do. Ideally, this protocol should be registered. That happens automatically when you go through Cochrane. There's also a registry called Prospero where you can register your systematic review titles. You then conduct a comprehensive literature search, focusing not only on the published but also the unpublished literature to avoid the potential publication bias by missing unpublished, potentially negative studies. You then apply your pre-identified inclusion and exclusion criteria, perform an ideally unbiased selection and data abstraction process in duplicate, typically by 2 independent reviewers, and then perform a critical appraisal where you look at the quality of evidence that these studies provide in aggregate. If appropriate, you perform data pooling in form of a meta-analysis, and finally, you interpret these results in the context of the clinical scenario and the quality of evidence that these studies provide. I think everybody in this room will agree that the Cochrane collaboration, as an international nonprofit organization dedicated to providing accurate and up-to-date information about the effects of healthcare, has pioneered the methodology for performing systematic reviews. The 2 main urology-relevant groups today of the Cochrane collaboration are the incontinence group based out of Aberdeen and the urology group in Minneapolis that I happen to lead. Systematic reviews are having an increasing role in the published urology literature. These are the results of a study that we recently published looking at all the systematic reviews that were published in 4 major journals from 1998 to 2012. And what you can see is an exponential increase in the number of systematic reviews that have been published, probably reflecting an increased awareness for the importance of these systematic reviews, but also to some extent recognition by the editors that these studies are typically highly cited and can help your impact factor. So as you see here, the number of systematic reviews published in 2012 alone equated the total number of systematic reviews published from 1998 to 2008 together. Now, it's important to me that you recognize that not all systematic reviews are created equal. And there's a lot of analogy to the cooking of a fish soup. Here, an example of a bouillabaisse marseillaise. I think you might all agree that before you get in line to get your own portion of this delicious-looking fish soup, you would like to assure yourself of two things. Number one, that the cook has used only the freshest ingredients, and number two, that he's washed his hands and knows what he's doing. And a lot of the same prerequisites apply to systematic reviews. Ideally, these are based on high-quality studies and are done in a rigorous manner by somebody who knows what they're doing. In the same study that I showed you before, we looked at the methodological quality of systematic reviews published in the urology literature. We used an instrument called AmStar, which provides 11 criteria by which to assess this quality. They then can be summed up to a score that ranges from 0 to 11, with a higher score meaning higher methodological quality. We then compared these two time frames, 1998 to 2008 and 2009 to 2012, to look at whether there had been an improvement. We found that the average score was approximately 5 and that there was really only a very small or possibly no change over this period of time. The mean difference was 0.5, but the confidence interval crossed 0. So in summary, we concluded that the quality of systematic reviews overall in the urological literature is modest, with little or no improvement over time. You might ask, where specifically did they fail to meet expectations? These are the results looking across these 11 criteria. If we focus on what we saw for the latter time frame for 2009 to 2012, we found that in half the time, there was no consideration of the quality of evidence. About only in a quarter of the studies did they consider the risk of publication bias. And finally, very rarely was there a consideration of both potential conflicts of interest of the trial authors of the studies that were included in the systematic review, or potential conflicts of interest of the systematic review authors themselves. So, evidence-based urology is not all about systematic reviews. Two other important movements in evidence-based medicine that all started in the 1990s are the one to promote clinical practice guidelines and the need to provide guidance at the point of care. As was discussed yesterday in the EBM session, systematic reviews and guidelines are both a manner to deal with the information overload that we all face. And finally, the evidence-based medicine movement that we associate with McMaster University, with David Sackett, that emphasized that every single one of us should have the skills to critically appraise a study. And this is where the evidence-based medicine actually has its name. So spending a little time on clinical practice guidelines, I really believe that clinical practice guidelines are where the evidence-based medicine rubber hits the road. This has been underscored by the recent report by the Institute of Medicine that had a report with the title Clinical Practice Guidelines That We Can Trust, and that defined standards for what defines a high-quality clinical practice guideline. And one of these statements is that clinical practice guidelines should be based on systematic review that meets certain Institute of Medicine standards, once again emphasizing the importance that systematic reviews have to guiding medical practice. One of the most inciting things that I've seen happen over the last 10 years has been the uptake of the grade framework in medicine in general, including in urology. So grade is actually an informal group of clinicians and methodologists that first met in 2000 with the shared aim of developing a methodologically rigorous and transparent and practical system to develop guidance documents. And GRADE developed a new system for rating the quality of evidence and strength of recommendations. And once again, it's a really informal group, and we currently have about 400 members. And if you're interested in what we're doing, go to our website, send us an email, and you can become a member and join in the discussion. So the GRADE working group, the GRADE approach has since been endorsed by over 85 organizations worldwide. These are their logos, and you probably recognize many of them. You have the WHO, we have the Cochrane collaboration, somewhere there should be NICE, you have SIGN, you have AHRQ, you have UpToDate as an information service. Altogether 85 organizations that are now using GRADE or something very similar as GRADE. What makes GRADE different? What makes GRADE unique? I'm just going to highlight 3 aspects of GRADE. So number 1, GRADE focuses on patient-important outcomes, and ideally these should be defined a priori before you begin the systematic review process or the development of a guideline. These outcomes are rated as critical for decision-making, important or less important. Second, GRADE focuses on the body of evidence as summarized in a systematic review. Also, the rating of the quality of evidence is based on this entire body of evidence that you found. And finally, the quality of evidence as per GRADE is based on more than just the quality of the study and potential study limitations or risk of bias. But GRADE has defined additional dimensions that affect the confidence that we have in the estimates, affect specifically things such as inconsistency, indirectness, imprecision, and the potential for publication bias, as previously mentioned. So as you might be able to tell, I'm very passionate about clinical practice guidelines, and I was therefore delighted to be part of this effort that brought together members of the guideline community from several professional organizations in urology, including BAUS, including NICE, the EAU and AUA, where we tried to map out a potential future for clinical practice guidelines in urology. And I truly believe that the use of a unified and transparent approach to rating the quality of evidence and strength of recommendations like GRADE would really empower better collaboration, would save precious resources, and ultimately improve patient care. And I think it's fair to say that there's a lot of interest at the moment among the leadership in the AUA and the EAU to adopt GRADE or something very similar that would facilitate better collaboration in this manner. Finally, I'd like to acknowledge the tremendous contributions that BJUI International has had towards promoting evidence-based medicine skill and training in the urology community. Nearly 10 years ago, John Fitzpatrick wrote an editorial with the title Evidence-Based Medicine Up Front, where he introduced the readers to BJUI International to levels of evidence as an identifier for urologists that had no specific skills in critical appraisal to get a sense of what the quality of evidence, what the trustworthiness of a single individual studies might be. Subsequently, 1 year later, Chris Evans wrote another editorial where he emphasized the importance of evidence-based medicine to all urologists. BJUI then went on to publish a number of educational materials to promote evidence-based medicine among urologists. One of them is this series called Evidence-Based Urology in Practice. These are relatively short articles where finite concepts such as, in this case, heterogeneity or publication bias or likelihood ratio are explained in the context of a urological example. So there are actually 15 articles that were published by the Evidence-Based Urology Working Group, and they've also been published in a supplement. And more recently, there was another series that is focused on diagnostic tests in urology. Once again, it uses examples from the urology literature to explain why certain concepts in EBM are important. In this case, a study looking at percutaneous biopsy of renal masses written by a group at the University of Ottawa. So coming to a close, systematic reviews are really important, but should use rigorous and transparent methods to summarize and rate the quality of evidence. They're also critical to clinical practice guidelines, and it remains important for every urologist to have the skills to critically appraise the medical literature, and I thank BJUI for its contributions in this area. Thank you very much. Be happy to entertain some questions later on, and otherwise feel free to email me or contact me via Twitter.
Philippe, stay there. We're going to take some questions from the floor. But while Frank Keeley is coming up, I just am slightly horrified when you mentioned on the AmStar score 2.7% declaration of conflicts of interest. Just before we came to BAUS, some of you may have come across the controversy between the New England Journal of Medicine and the BMJ about conflicts of interest, completely polar opposites. So I would very much like to know what your position is on COIs.
So I think the numbers are so low because studies needed to meet two criteria. They needed to show us data about the individual trials they included, about their conflict of interest, so whether they were industry funded or whatever. And they needed to disclose their own potential conflicts of interest. So these two things had to be met at the same time. I think this is an easy thing to fix and is something that we need to fix. I think those are things that we need to provide our readers with. I don't think there's much discussion there to be had.
Frank Keeley.
I was wondering, thank you very much. It was a fantastic talk, and I'm going to focus on the same question, which is what can be done to raise these standards. And I wonder if people like Prokhar and his editorial team can be more rigorous. And I'm not picking on you, Prokhar, but we see every month another meta-analysis, systematic review where it's garbage in and garbage out. And it's dressed up, but it shouldn't be called a systematic review if it's not systematic and it's biased and all the rest of it. And it's addressing very important clinical questions in urology for us as clinicians that, we don't want to have a systematic review that's false or potentially false. And we just wondered what we can do to raise standards in the publishing world.
So I think everybody has a responsibility. I think every reader should reject a systematic review, should have some understanding how a well-done systematic review should be conducted, and reject those that are not well done. And I think editors have an important role, and we had a very productive discussion last night of what we might be able to do for BJUI. And I think there might be ways in the review process to enforce higher methodological standards.
So, Philippe, we receive a number of health services research papers. You may know that I brought in Kwok Trin as one of our associates to deal with this large volume of work that we receive. How does one look at systematic reviews and HSR papers as an editor or as a reviewer, and on face value try to decide whether it is worth sending out to review or should be immediately rejected? How does one do that? 5 key points, please.
5 key points. Thank you for making my life easy. I'm not sure about the 5 points, but when it comes to systematic reviews, this AmStar tool is actually relatively easy to use, and it is actually used as a screening tool by organizations such as CDATH, the Canadian organization that looks at new technology, that are looking for systematic reviews to guide their decision making, whether this should be covered or not. They will apply this AmStar tool as a screening tool to look at whether they will look at the systematic review any further. And studies that score at 4 or less will just be discarded. So that it actually shouldn't take your reviewers or your editors a long time, and this might be a practical way of dealing with some of the systematic reviews errors. Now, I obviously don't know what your most common problem is, but as a reviewer, when I get systematic reviews, there are lots of systematic reviews that come from China right now, and I think many times they're methodologically well done. They go through the motions, but it appears sometimes, and I don't want to generalize, and so obviously somebody that has ties to that country here, and this, so don't get me wrong, but many times what is missing is the ability to put that systematic review into a clinical context. So this is just not a mechanical exercise, or many systematic reviews are done by non-urologists on urology topics. And we see that in Cochrane too. We did a study where only 1/3 of Cochrane systematic reviews actually include a urological author, which I find very problematic and is one reason why some Cochrane reviews read awkwardly and don't have a lot of appeal to urologists. So.
Philippe, that was masterful. We thank you for traveling all the way and for sharing your experiences with us. Thank you very much.
Thank you very
Philippe
much.
Dahm.